Good morning, everybody. Thank you and welcome to this morning's meeting. This morning's presenter is Dr. Cornel Engelbrecht. He is a physician at Mediclinic Midstream Hospital, and he is a very important team member in these presentations and also in practice. He is presenting a very common topic, syncope. Cornel.
Yes, thank you very much, Leanne. Thank you for allowing me to do this talk. Yeah, we see this quite a lot. So I thought, especially for the EC people, we'll do the approach to syncope in the EC. Don't let syncope knock you out. So it's not going to be a very long presentation. We'll look at the terminology, the differential diagnosis, especially looking at your life-threatening conditions, your common conditions, and then important, the history examination, what test needs to be done. So yeah, to start off, syncope is the transient loss of consciousness associated with your loss in postural tone, followed by spontaneous return to baseline neurological function, and that's quite important. You don't need any resus efforts. It is quite common, and the causes can be either benign or life-threatening. And especially for EC, it's important to identify these high-risk patients. And it's also important to distinguish true syncope from other conditions like your altered mental status, strokes, dizziness, lightheadedness. And then pre-syncope should be evaluated in the same manner as with syncope. So as we already said, that syncope is the loss of consciousness. The underlying mechanism for this is local cerebral hypoperfusion, or you can have focal hypoperfusion of the reticular activating system. Quite common, as we said, 1 to 2% of ED visits, and your lifetime prevalence is about 10 to 19%, so 1 in 5. Pre-syncope is the near syncope or loss of consciousness. If there's a cardiac reason for syncope, it can increase your risk actually by 2 times compared to a neurological cause. If the unknown cause of syncope, the risk can be about 30%, while vasovagal syncope is not associated with an increased risk in mortality. As you can see from this slide, the highest incidence of deaths is in cardiac diseases, followed by neurological conditions. So the important thing about syncope is to look for life-threatening conditions. We'll look at common conditions and then your other conditions. So the first important step is identifying a life-threatening cause for syncope. So there it can be divided into your cardiovascular syncope, important arrhythmias, your VTs, your QT syndromes, your Brugada syndromes, your bradycardias, your heart blocks, and then also if you have significant sinus pauses. Ischemia, quite an important cause, your acute coronary syndrome, myocardial infarctions. And then your structural abnormalities, that is your valvular diseases, your cardiomyopathies, and then very rarely your atrial myxomas. Cardiac tamponade can do it as well as your aortic dissections. The second life-threatening cause is significant hemorrhage. That's usually associated with trauma with quite significant blood loss, gastrointestinal bleeds, and then your aortic aneurysms, livers rupture, ectopic pregnancies. Pulmonary embolism, especially subtle embolisms, can present with syncope, and then your subarachnoidal bleeds. As we said, other serious conditions to consider in life-threatening conditions is seizures, strokes, head injury, although it's not technically syncope. Common conditions that can present with syncope is your vasovagal syncope, also known as reflex syncope. Quite a common cause, about 25 to 65%, and they have an excellent prognosis. And there's usually cardioinhibitory response, your vasodepressor, and gives you a mixed response. So these conditions are, they have certain triggers, and you will have to find out what the trigger for the patient is. This patient usually presents with dizziness, warmth, they feel nausea, they can have pallor, change in vision, abdominal pains. Your carotid sinus hypersensitivity is a reflex mediated and is usually due to pressure at the carotid sinus. This we see patients who's shaving, they will have a tight collar or turning off their head. And then the last one is orthostatic, and this is usually we have a drop of a systolic blood pressure of more than 20 millimeters with positional change with reflex tachycardia. So sometimes they say that, especially if the systolic blood pressure is below 90, but the important thing here is you need to have a systolic drop in blood pressure of more than 20 with symptoms. Some patients can have a blood pressure drop of more than 20, but not have any symptoms. And it's usually due to the loss of IV volume with instability, and we see it as well with autonomic conditions like Parkinson's, especially in elder patients, and then also with GIT bleeds. Medications is quite a common condition, and most of our patients will be on medication. So your calcium channel blockers, beta blockers, your nitrate, your antiarrhythmics, and then also your diuretics. And then the other ones to consider is your antiemetics and antipsychotics, which can influence your QT interval. So if we look at the common causes, you can have neurocardiogenic, and this is where you have conditions like micturition, defecation, coughing, deglutination, so swallowing after eating, your glossopharyngeal stimulation, and then also situational. As we said, carotid hypersensitivities, your orthostatic syncope, and then also your medications. So this is just a nice picture of how everything is integrated. So you've got neurally mediated syncope syndromes. It will affect the afferent pathways, which then will influence the heart, and you can have bradycardia, vasodilatation with hypotension. So other conditions to consider is neurological syncope. As we already said, that to syncope, you have immediate and spontaneous return of your neurological function, and there's no neurological defect afterwards. But with neurological syncope, you can have underlying neurovascular disease. It is quite rare, and we see it in complex migraines, TIAs, and subarachnoidal hemorrhage. Strokes and TIA generally generally causes focal neurological deficits, and they do not recover rapidly or completely. And patients who have an underlying cerebrovascular disease will have a history of non-syncopal episodes, and they usually have other associated symptoms like diplopia, vertigo, focal weakness, and then numbness. I think an important thing is what's the difference between syncope and seizures. And a lot of times syncope might be seen as patients having seizures because patients who have syncope can have this transient loss of consciousness. They can have brief convulsive episodes, and it's usually due to the hyperperfusion, especially if people are trying to keep the patient upright. And then the things that differentiate syncope from seizures is like the brevity of the convulsions, the absence of auras, incontinence, tongue biting, and then also the lack of this post-ictal phase, which we see in patients with epilepsy, which lasts usually longer than 5 minutes. Then other conditions to consider with syncope is also psychiatric syncope, where anxiety and panic disorders, we see that actually quite a lot. Drug-induced loss of consciousness, drugs of abuse, alcohol, we get from time to time. And then also your metabolic conditions, hypoglycemia, hypoxia, and then your electrolyte disturbances, especially in patients with renal failure. So then there's also a couple of conditions that's incorrectly diagnosed as syncope. And you can have disorders with partial or complete loss of consciousness, but they have normal or without any global hyperperfusion, your things like epilepsy, your metabolic disorders, intoxication, and then your DIAs. And then you also have disorders without any impairment of consciousness, your cataplexy, your drop attacks, falls, and then TIAs of corrupted origins. So if we look at the history, the important key elements is the age. The older you are, the more risk of adverse outcomes you have. If you have associated symptoms like chest pains, you would think about ischemia, palpitations, tachyarrhythmias. Dyspnea can be pulmonary emboli, headaches. You have to think about SIH or intracranial bleeds. The position gives us a good idea. So especially if you've been standing for a long time, you would think more vasovagal. If you're lying to standing, you think orthostatic. And if you're in supine or sitting position with syncope, you would think more arrhythmias. The onset, usually if it is sudden, it's arrhythmias, while if it's gradual over time, you would be more vasovagal. And then exertional syncope, you would think of arrhythmias and your cardiac outflow obstructions. And then once again, just to briefly differentiate between seizures and syncope, you would look for the prodrome phase, eye deviation, the abrupt onset associated with injuries, the presence of a tonic phase before clonic activity, head deviation, and unusual posturing, tongue biting, your loss of your bladder and bowel movement, and then also this prolonged post-ictal phase. And other things to consider in your history is the medication. You always have to inquire about what medications patients are taking, and then prior episodes. So if it's single or multiple over years, it's usually benign. And if it's several over a very short time, you would think more significant causes. Family history of sudden death, dysrhythmias, and then also cardiovascular disease. So in your physical examination, look for transient hypertension, bradycardia, and all patients, you have to check the blood pressure and make sure there's no orthostatic hypotension. You would listen for murmurs and abnormal sounds in the heart. Pulmonary examination, look for crackles and wheezes. Do a full neurological exam with vocal deficits. Always examine the neck for carotid bruits and look at the JVP. You can look for GIT bleeds, especially if you think about hemorrhage. Look at the tongue for tongue lacerations and then examine the patient for any associated trauma. So we can divide syncope in high risk and low risk factors. So the factors for low risk is usually the age of the patients. If the patients are younger than 40, if they have syncope only while standing, if they have especially if there's an orthostatic component, nausea, vomiting before syncope, feeling warm before syncope. And then also, if there is a prolonged history over years, it can be associated, it's usually low risk. Then your high risk factors would be if you have syncope during exercise, and then the things that we always ask for, if it's in the supine position, if there's chest pain, dyspnea, or palpitations. The other factors that's actually quite important is, and we've already touched on this, is if there's a family history of sudden death, if you've got heart failure, aortic stenosis, LVH outflow obstruction, cardiomyopathies, so all the cardiovascular components, and then also the patient has pacemakers or defibrillators implanted. So all patients in issues should receive an ECG. The diagnostic yield is quite low, but it's inexpensive and it's part of your stratification. And assess for mainly two things, arrhythmias and ischemia. So the important findings that will alert you is usually if the patient doesn't have sinus rhythm, if there's a new left bundle branch block, or if there's signs of ischemia. You would also then look for your QT intervals, and then also your conduction abnormalities. Once again, the things that will alert you to an arrhythmic cause, there's quite a few of them. Look at the ECG. So just to touch on Brugada syndrome is where you get this features of a right branch block with ST elevation in leads V1 to V3. You should investigate these patients further. Cardiac monitoring in the EC can be quite useful, especially if you're looking for your arrhythmias. Your tachyarrhythmias or atrial tachyarrhythmias can give you syncope, but usually if a patient has normally structurally heart, it shouldn't be a problem. Then consider electrolytes, your hematocrit, especially if the hematocrit is low, you have to think about a bleeding cause. Coagulation studies, pregnancy, and elevated pro-BNP actually predicts an adverse outcome. So should be done for all patients with syncope in EC. And then also your drops, if you think there is underlying ischemic heart disease or coronary artery disease. Once again, as we said, you have low risk factors, high risk factors. For high risk factors, if the HP is low, the systolic blood pressure is less than 90 millimeters square mercury, and then also sinus bradycardia. And we've already touched on the ECG features, and that would make a patient a high risk for an adverse outcome. So other diagnostic testing, neurological studies, CT brains, MRI, especially if you think a patient has a TIA, stroke, or a new onset seizures. Once again, the diagnostic yield is quite low. We probably overuse it, but it is one of the tests that we use. And then if you think that the patient has underlying seizures, an EEG might be helpful. Echo, if you think a patient has a structurally abnormal heart, you will especially look for things like pericardial effusions, pulmonary hypertension, and valvular diseases. So how do we approach the diagnosis? The key questions would be, is it truly syncope? Is it life-threatening? Is the patient high risk? And then, as we said, the life-threatening causes would be hemorrhage, PEs, and then your cardiac syncope. Risk stratification. There's a lot of risk stratification tools that you can use, but it shouldn't replace your clinical judgment and that gut feeling. And this will determine the patient's risk and disposition. As we said, the ECG abnormalities and the history of heart diseases are the major risk factors. And as I said, there's a couple of scores that you can use. And as you can see with all these scores, and this is where the pro-BNP comes in, the hematocrit, ECG abnormalities. So they all have different risk stratifications. So if the patient comes to EC, the first question would be, is it truly syncope or not? You would then do your history, your examination, and come to a conclusion. So the features why you would think this is more syncope is if there's the absence of heart disease, a long history of recurrent syncope, sudden explained unpleasant sight, sound, smell, pain, prolonged standing, nausea, vomiting during a meal, and then also if there's head positioning rotation, I'm thinking about pressure on the carotid artery. And then your syncope due to orthostatic hypotension, usually after standing up, if there's a relationship with drugs, crowded places, hot places, if you think there's autonomic neuropathy, Parkinson's, and then also standing after exertion. So if you think it is syncope, the next step would be, is there a dangerous cause? It can be either yes, and we've already looked at what would be the causes for yes, or if you think it is possibly just vasovagal. The next step.
So vasovagal is not dangerous.
No,
Vasovagal.
vasovagal is not dangerous. No. If you have unexplained syncope, that is, you couldn't get from your history, you would then do a risk stratification. You can then divide it into a high risk, an intermediate risk, or a low risk. And then, as we said, and we'll get to that, so what would be the high risk criteria for patients with syncope? So once again, abnormal ECG, structural heart disease or heart failure, a systolic blood pressure that's less than 90. If you have shortness of breath, a raised drop, hematocrit that's less than 30, older patients, and then your family history of sudden cardiac arrests. So there is certain maneuvers that you can do, especially if you have recurrent syncope attacks. And they call it physical counter pressure maneuvers, where you can do leg crossing, arm tensing, or even squeezing an object. You can also do lifestyle modifications, where you can increase your fluid intake, salt intake, lying down when these symptoms come. And I found that your physical counter maneuvers have actually a better outcome, especially in patients with recurrent syncope attacks. This, I hope this projects it quite well. This is something that we get quite a lot, is the recommendations of resuming driving, especially after syncope. And it can vary from 1 week to indefinitely, depending on what the underlying cause is. Yeah, basically. So just to summarize, first of all, assess for your life-threatening causes, differentiate true syncope from other conditions, and the key causes would be cardiac hemorrhage, pulmonary emboli, and then subarachnoid hemorrhage. Obtain an ECG on all patients, use a stratification tool, and guide management to your disposition. High-risk patients, we would admit and investigate. If there's an intermediate risk, you can observe the patient. And if there's a low risk, you can actually discharge the patient and then just follow the patient up. And this is actually quite interesting, and it is the dance of syncope. A sudden faint, a fleeting spell, the body's tale it seeks to tell, a mystery wrap in transient case, syncope shadow we must chase. First the story, the witness voice, a moment fall was its choice. Preceding aura or sudden black, the history's map guides us back. Was it the heart, a rhythm gone wrong, or vessels lax, blood pressure drawn, orthostatic whispers or sheath's might? We sift through the clues in the clinical light. This may follow, ECG trace, blood work and echoes to find the place. Yet off the answer lies in the tale, syncope's veil we gently unveil, a careful dance, a thoughtful quest, to find the cause, to give them rest. For in the faint, though brief it may be, lies a story of life's fragility.
Well done, Cornel. That was quite very nice syncope presentation. And I think probably you just summarized everything so well. So I always say that the patient who presents a casualty ED with the syncope, there are very few tests that you could actually do immediately and give you the answer whether you should walk, run, or go to sleep. One of them is the CK levels, prolactin, and then of course your troponin T, and that probably, and then proBNP. And I think, and then of course, UK looking at electrolytes. Now, if your electrolytes is normal, your trop T, CK, and prolactin every normal, that excludes the dangerous your epilepsy, exclude your cardiovascular. That means you might have a window of opportunity can't work this patient up. And I think probably the age of the patient also matters. You know, young people with normal ECG, obviously you're concerned about arrhythmias. That's really what it's about. But also you have to look at the anxiety sometimes that have more prevalence than actual arrhythmias in those patients. And then of course, if they're older, I always say anybody above the age of 60, you should always admit this patient in their proper workup. You can't just, you need to find the cause, because most of them, I always remember my own mother who had syncope and she woke up at a few minutes and she thought so as well. She went home, no issues. And then the next time when she had it, she never made it. So syncope can be really, really a serious medical problems. And especially in societies where it's easy to say, oh, she's well now. She just had syncope, she's well, because most of them, they recover fully, they got to their normal functions. But then the problem that is always, I always say, warning before the storm. So I think above age of 50, you should actually spend time on them and investigate in more detail, get neurologists in, get cardiovascular in, do Holter, do your carotid Dopplers, do your CT coronary, because sometimes carotid Doppler can miss the lesions above the bifurcation of the
So you should actually do CT angiogram if you want to see carotid stenosis.
Yeah. So I always SIP in my mind since I think my mother passed on a few years ago. I always make sure to do CT coronary, CT out carotid, and I think I pick up almost 7 to 10 cases that require stenting. So I think it's a very important topic, but I think it's special for physician to be managed properly together with neurologists. What do you have to say, Dr. Stein, our principal neurologist in the country?
So what we were taught is it's called you have to look at the heart first and then go and search for neuro.
That what kills you first, to
kill you in the acute phase. Also, just in terms of that orthostatic intolerance definition that you had. So what's important, systolic, that drops more than 20 and is symptomatic. Because I've had people phone me at 3 a.m. saying the diastolic drops by 5. But I mean, that is not, it is not part of the definition, even though it does say that on UpToDate. I've seen it myself. So that is not really part of the orthostatic intolerance criteria. And even in EC, I do expect you to do a supine blood pressure and let the patient stand up for about 3 to 5 minutes and then repeat it and just see, is there not really an orthostatic problem? And it can really, really guide you where to go and look next. Because in all the patients, it's most likely going to be medication more than half the time. And then in younger patients, you have other conditions which you also don't know mention, but that's a can of worms for another day, is postural orthostatic tachycardia syndrome, which we see much more in the younger patients. And then the other sort of trap that one can sometimes fall into is if it's a younger patient, you think it can't be cardiac. It can definitely be cardiac. We've had a couple of patients where it was like a viral myositis or not viral myocarditis. We've had one PFO. So don't fall into that trap where you think it's a younger person who can't be cardiac. You will eat your head.
Yeah, I think cardiac is always, I think cardiovascular. I think probably midstream we have really gotten quite well in diagnosed cardiovascular disease than any, And the thing is that I think you must always have a high index of suspicion. Now, I always say that if you have come through and see a patient with syncope and you make a spot diagnosis, then chances are good that you need to retire. Because I think syncope is not as straightforward as we think. And you really need to go through the motions. And I think the moment you go through sequential, you will always find something, whether it's psychosocial. I mean, if somebody with anxiety, and they will not just have a syncope, they probably have what's called dysfunctional breathing. That you will find that actually having hyperventilation problems, they're probably having chest pain, a lot of issues. So, and I always say syncope in young people, if you exclude cardiac, then you look at the next problems, the partner in the bedroom. Become the cause. So you need to make sure that whether there's any social issue at home, and most of the time you pick that up, But if you don't have any above, please need to find more details. You need to kind of investigate these patient details, look at your electrolytes, and also look at rare conditions from autoimmune diseases, which can give you syncope, pulmonary embolism can give you syncope, electrolyte abnormal can give you syncope, and actually, I mean, what else? I think also drugs, isn't it? Drugs withdrawal, and also antipsychotics, you know. So the list can be endless. So something I want to think about.
You have to start with a good history and look at your patient. Half of the time, you already have like a list of things to do when you just look at the patient and listen to what they say to you. And then you ask your specific questions. And then you know where to go and focus.
When do you think is the role of EEG on this patient?
So sometimes you have to be very careful because you can have a false positive EEG. So you also just, I mean, in 5% of patients, you can have interictal discharges and it's not really epilepsy. So you have to be careful to just do an EEG. If there's any index of suspicion, then I would recommend that. But sometimes I just do a 20-minute. If I don't think it doesn't sound like true epilepsy to me, I don't go out and do a 24-hour EEG. Especially if there's obvious other causes. I think it's a waste of resources. The other thing in terms of neurology, like if it's a stroke, it will be very rare that the patient actually loses consciousness. It has to be then a huge posterior sort of infarct. It's very rare that a stroke will just come in with syncope and loss of consciousness. So I wouldn't put all of my money there first.
And the role of sleep studies, obesity, syncope, isn't a big conflict, isn't it? You might not actually have the really straightforward answer because, I mean, if they're obese, I mean, you might need a sleep study on those patients. So I think when they have syncope again, you need to think about if the BMI is more than 31, think about obstructive sleep apnea or. But they might not have cardiovascular problems, just plug-in tightness. Some plug-in tight and they're on anti, because remember, if you have severe obstructive sleep apnea, you're on anti, they got the what they call executive brain, like, I mean, most of the time they tend to be depressed or anxiety because lack of sleep, and then they go to GP, they get antidepressant treatment, and then the process now, when they're driving, they could have syncope, isn't it? Then out of blue, you find that actually if you correct that sleep study, you correct the depression, you correct everything else.
But I had a patient a week or two ago that came in that accidentally just gave me a letter from the GP saying that the patient has narcolepsy and he needs to be seen by. So I asked Dr. Stein to look at the patient for me. But it actually turned out to be sleep apnea, as you said. So you have to exclude sleep apnea first before you can call it narcolepsy.
Yeah, and also if you just spoke to the patient and he explained to you what happened, then you wouldn't call it narcolepsy as well. Remember, it's very rare that an older patient will present with narcolepsy.
Yeah.
And there are specific criteria, but the first criteria is actually to do a polysomnogram to make sure that they don't have sleep apnea.
But I mean, I haven't seen a patient across narcolepsy, I think, since my career days. You know, it's not very common. So I think it would be brilliant to just make that spot diagnosis.
Yeah. Look, you have to be very careful, like you said, to just make a spot diagnosis. Be careful of these patients, but also don't over investigate.
Yeah. I think it's important because it's very expensive if you're going to go through the details. I think someone who is less than 40-year-old is not worrying city Arctic. You understand? It doesn't make sense. Yeah, so I think that the cuts of 50 years would be okay, but then of course the risk factors and others, that's what we should be looking at ideally. And then I mean, so again, syncope. I think the witness is always very important when the event happens. Who is present? I think you always need to find out in the history because they will tell you whether the patient having epileptic fits or the eyes just turn upward. If the eyes just goes and no movement, you think it's more cardiovascular as compared to when they actually got those jerky movement and that. Yeah.
So it's very interesting. we've seen this a couple of times in our lab where we do conductions and EMG. So especially male patients, they tend to faint when we put in the needle for EMG. And quite a few times, I mean, they're sitting up, they faint, and then obviously they don't lie down immediately because they're in a sitting position. So they have these sort of myoclonic jerks for a few seconds, and then we put them.
Why male patient? Can you tell us?
It's only the males.
Why?
I don't know. We should understand. It's an absolute fear response.
I think on the pulmonology side, we do having male patients actually they do paint when they actually come to blow. And we had one last week that Dr. Engelbrecht actually sent to one of the labs for blood drawing, and he had a syncope there. And he was admitted to ICU. And I think the issue that they tend to, because of the fear, they have anxiety to needles, then they tend to hyperventilate. And what will happen that now out of we find that actually sometimes the excess for deep inside that they increase their lung volumes, and that actually cut blood off from the right ventricle to return to the heart, and that normally give them the kind of syncope. So, but again, but if you investigate, you don't find something. So it's males that are fit, not those who are pride.
They're always very
athletics.
They're very large.
Yes. Yeah.
And you have to catch them.
So it cannot be me. Maybe Engelbrecht.
Yeah, but it is interesting. Even if you look at some of the data from patients fainting on planes, so they typically also have these myoclonic jerks. Some of them even lose bladder function.
Yes,
and it's syncope. It's not
real.
It's not a seizure. So you have to. That's why you have to speak to the patient as well and find out what happened. If they had this flushing, they saw tunnel vision. If it sounds like more a seizure that was preceding or a syncope that was preceding all of this. Then it's very
on the witness.
you can't always because the witness will tell you no, his eyes rolled back and he was shaking and then he beat himself.
Yeah, no, I agree. Yeah, peeing is not a bad idea, but yeah. All right.
Rakesh has a question.
Rakesh?
Is there ophthalmology?
Morning, everyone.
Do you think is there ophthalmic cause of the syncope? Are you gonna tell us?
Yeah, so yeah. On my side, I kind of do see some syncope about twice a month. Healthy young patients. Some of it's mostly vasovagal. It's well known in the ophthalmic community where patients being examined have this vasovagal, they get tunnel vision, they start feeling dizzy, and they may have a myotonic jerk type of movement, and then they pass out. It's mostly young patients, and a lot of it is attributed to the oculocardiac reflex, which causes bradycardia when you manipulate the eyeball. So I see it quite often, and the colleagues all agree that it's not worth working up. It's the first time it happens for a lot of the patients, and patients are generally healthy. I have sent some of the patients through to emergency department, and nothing was found after complete workup. So I just wanted to make everyone aware of that. Yeah.
So Rakesh, is there any single particular test that you could do with confidence and say, how do we know it's oculo, related? I mean, most of the time, we have seen a lot of syncope. We never really sent to ophthalmologists. What would be the criteria for us to actually make sure that ophthalmologists are involved in working out with these patients?
No, look, the workout is going to be on your side. There's hardly any workup on our side. It's just for manipulating
Stop touching the eye.
It's just from manipulating the globe or maybe moving the globe and being close to the eye. A lot of it is also anxiety based,
Yeah.
like Lisa's patients with the needles. A lot of it male patients, but young females also get it on my side. So it's a well-known phenomenon. We see it in theater, especially when you're manipulating the globe and you see the pulse drop to 40, 45.
What about
So-
patients that are driving most of the time with eye problems, then visual issue, then they have accident, and then of course they will have syncope. People will call that a syncope, but actually find that they got a straining of their eyes and they can't
Yeah.
see properly,
Yeah.
especially when they're tired. Isn't it when you're driving? Sometimes you tend to see double visions. As one of the causes, isn't it? I think the thing, if you can't find anything, maybe they need to be screening.
Yeah.
Because I'm
So
resistant to glasses,
So
Yes.
there was a patient who had proliferative diabetic retinopathy. He ended up being in a crash, and on examination, he had this vitreous bleed. So the question was, did he have the bleed before the crash, which caused the crash,
From trauma.
Yes.
or did the bleed happen post crash?
Yes.
And this was he had diabetic retinopathy that caused that in that
Yeah,
case.
interesting.
So it's also difficult to decide which came first.
Yeah.
So yes, I've started giving them a little bit of saline immediately when they start complaining of dizziness and a bit of tunnel vision, and it's kind of helped. Because it's young, healthy ladies mostly.
In
No,
the mouth.
Yeah, I just gave them to drink a small 10 ml saline for injection, and it's worked.
Okay. It's a good idea. I'll keep saline close by.
Yeah, but I like the idea of squeezing something, so maybe I'll get a stress ball.
Yeah.
For them to
Yeah.
squeeze, or maybe they can just squeeze my hand.
They like to squeeze before they fight.
I mean, if you get that salt water in your mouth,
Then you have other problems.
I mean, it depends a lot on your history. Now, all the patients you would tend to investigate more. If it's recurrent episodes or a first episode, what was the preceding symptoms?
it's very old. Come and fall and hurt themselves as well with the syncope. Obviously, them, they're all on loads of medication.
I mean, I admitted a patient
It's more extensive work up here.
in ICU. Your patient, that Lauren admitted. I mean, she's got chronic slow AF, but she's on amiodarone 200 milligrams BD. She's on a beta blocker and she's on Coex Forge,
Yeah.
160. So her pulse is 55 now.
Yeah.
So
What do you think?
so now she keeps on falling over. Sinus stenosis as well, but so it's important. So, and I think sometimes we overtreat a lot of the patients.
Yeah.
In hospital.
Look, I think if I remember last year, early December, we have one of the patients that got admitted, it's non-patient to us, to ICU with the syncope and final bradycardia of 3, was 40, and she was scheduled for pacemaker. Then I got consulted. When we look at it, we found that we actually discharged the patient on amiodarone and beta blocker. And the cardiologist didn't even look at that. Family was discussed everything, patient was going, then say no, the patient cannot go. And then the following day, heart rate back now. So sometimes I think in medical history is very, very important. And remember that actually when I was my 21, 22, I had my syncope in the as a medical students. You always give that a lot. And I think I remember I was in hurry, I had a bit of conflict, and I went to the thing with the sugar. And I think we stand a lot in theater. Also because of the overcrowding.
Yeah, that's when I realized I'm going to surgeon.
Yeah, then I found myself on the floor. I remember. So once of syncope is not really a problem. I think for someone younger than 30-year-old, you don't investigate those. I don't know, maybe 40. I'm not so sure.
We all
One
find
thing is,
from time to time.
So one thing.
Oh, you also did that? Okay. So I was not unique.
The patient, I was just like, no, thanks.
Yeah, and most of them is really hunger, isn't it? The
You've got your gown, your mask, you're breathing on your own face, you're wanting to feel hot.
But remember the girls were admitted also, but she had not 2 episodes syncope that we admitted with, and then we woke up and always when she fainted, she got low sugar. And I think we actually found something interesting. I think probably we're going to present her in 2 weeks' time. So again, but I think single episode, yes. Second episode, I think please, basically.
And also one other very important thing is I think we should stop over treating blood pressures.
Yes.
Especially in elderly patients. There are still a lot of doctors out there who believe that the blood pressure should be 120, 80. At some point, our guideline even said that your blood pressure needed to be 120, 75 if you were diabetic. And now we know that those patients actually do worse, and that's not what you're aiming for. And if you do that to an older patient, obviously they have stiffening of their arteries and things. They will have an element of postural hypotension, which is normal part of aging. Now you're over treating the blood pressure. They have no blood pressure when they stand, and then they do.
Yeah, that I think I agree.
In Europe, the guidelines say 160, 90. And I had a patient the other day, 88-year-old, and I checked her blood pressure in my office, and now since withdrawing some of her blood pressure medication, her blood pressure is 159/95, but she has not fallen since since we've corrected that. So it's
I think yeah.
Sorry, like one of the common things that I found, especially in elder people, complaining about feeling tired and weak, is beta blockers. Beta blockers is known for causing so
it's a good habit to have, especially in an older patient. Just do the blood pressure while they're lying down, standing up.
yeah.
It's the quickest way sometimes to just actually figure out exactly what's happening.
Yeah,
actually, there should be like a standing order, and I'm trying to do it more in the ward. If the patient gets, this is the standard things that they must do.
Just do it.
no, I think the problem in South Africa that we really, I think most of our societies are really extremely very weak because we don't really. If you look at the guideline that's produced in South Africa, it's always 5-6 years down the line. It's not updated. Like the question that I think clinicians should be actually putting the guidelines every year. Because I agree with Dr. Godinho. I think I read to what you just the blood pressure. You only start treating when it's above 160, 90. And that's already, I knew that already, I think 7-8 years ago when I did presentations. But I think I remember I had, yeah. So I know one of the lady that had issues. So I kind of stopped her medication. But then the daughter kept going to the GP. Now there's conflict between me and the GP. They wanted the blood pressure. I said, no, you still got osteoporosis. You want a low blood pressure?
So
Exactly. And she's 83.
the other problem with older people is they're all on sleeping tablets.
Exactly.
So now they drink sleeping tablets and a blood pressure tablet at night. In the middle of the night, they have to go
To the
go to the bath.
Because she was on blood pressure and there's abdominopty. Other doctors said,
No, I think it's crazy. So, but I think but that's for me. It's the reality. But thank you, guys. If there's no extra question, can we call it this a quit? Thank you, Dr. Engelbrecht, for your presentation.